My name is Annie Wilkinson. I'm a health systems researcher at the Institute of Development Studies. So this lecture is about a major but subtle shift which is happening in global health. I'm referring to the steady expansion of laboratory capacity and with it laboratory-based ways of defining and measuring disease, which are increasingly reference points in the provision of medical care, but are also underpinning large health and development programs and the way they are designed, monitored and reported. The lecture is split up into three parts, the first of which covers the theme about extending the laboratory. The second looks at reflections on diagnosis from the social sciences, and the third part looks at the implications of this for emerging zoonotic diseases. The background to this is that laboratory medicine has historically been underdeveloped and under-prioritised. Laboratory infrastructure is limited in many parts of the world, and especially in low-income contexts. It has been described as an Achilles heel in the global fight against infectious diseases. Looking back at the last few decades of global health, laboratories, and by association diagnosis, appear to have been a bit of an afterthought. It would not be too strong to say that they had been marginalised compared to treatment. Indeed, the push has been to extend low-cost treatments to poor people, especially for the most common diseases such as malaria. Figures of expenditure in healthcare and in research and development reflect the way that diagnostics have been undervalued and underinvested. A study in the US found that diagnostics accounted for 5% of hospital costs but influenced 60 to 70% of decision-making, and the amount spent on diagnostics in African hospitals is likely to be much smaller. In 2004, the amount spent on research and development for malaria was $323 million, of which less than 1% went on diagnostics, while 37% went on drugs and 24% on vaccines. These unbalanced figures are in turn reflected in methods of disease control, for example in mass treatment programs or in the promotion of presumptive treatment, that is, to give someone a treatment before or without the result of a diagnostic test. For example, the World Health Organization recommended presumptive treatment with antimalarials for all childhood fevers in malaria-endemic countries until 2010. The 2010 guidelines now recommend a test and treat strategy. Periodic presumptive treatment has also been used to treat sexually transmitted bacterial infections in sex workers. Presumptive treatment is by no means limited to high-risk groups or low-income settings. A lot of medical treatment in Western settings is presumptive. For example, the course of antibiotics a doctor prescribes a patient with cold and flu-like symptoms. Treatment is often the first stage of reaching a diagnosis. A patient or doctor tries one course of treatment on a hunch, and then if that doesn't work, they try something else, eventually narrowing it down. However, because most non-severe illnesses do eventually clear up, the assumption that treatment was the cause of the recovery is common but often incorrect. However, diagnosis and diagnostics are increasingly prominent in the provision of health services, especially with diseases like malaria, HIV and TB, but not confined to them. A number of factors have influenced the expanding role of diagnostics. These include major advances in diagnostic technologies, for example, the development of rapid and mobile tests, which makes diagnosis possible without laboratory infrastructure such as cold chains, increasing recognition of drug resistance and the understanding that poor diagnosis has been partly to blame for this, as inappropriate use of drugs stemming from misdiagnosis or the absence of diagnosis accelerates the development of resistance. Drug resistance is increasingly a problem in the face of bacterial diseases where antibiotics are increasingly less effective and for diseases such as malaria and HIV. Key global health funders have put considerable investment into stimulating the development and use of diagnostics, for example, the Gates Foundation and the Wellcome Trust and the World Health Organization. Related to this increased investment, there are a number of organizations whose aim is to design and promote effective diagnostics, such as PATH or FIND. The extent of diagnostic expansion has been dramatic in the African region, as you can see from this graph from the 2014 World Malaria Report. In the African region, the proportion of suspected malarial cases who received a diagnostic test when attending a public health facility went up from about 10% in the 2000 to over 60% in 2013. And as you can see from the darker grey bit on this graph, since about 2006, much of that growth has been down to the use of rapid diagnostic tests. These developments in diagnostics are accompanied by considerable expectations. For example, a Foresight study concluded in 2002 that modified molecular technologies for affordable, simple diagnosis of infectious diseases were the area of biotechnology predicted to bring the most improvement to low-income health systems in the next decade. As with all science policy developments, it is important to think about what stories are being told about these technological advances. In this case, the key idea is the apparently neutral and simple idea that new diagnostics have made accurate scientific diagnosis possible in settings where it was previously impossible. However, on closer inspection, that contains some underlying assumptions which are worth questioning. They include the implication that scientific and specific diagnostics will replace symptomatic or intuitive medicine, which is deemed to be or pre-scientific, that it will replace presumptive treatment, which is cast as crude and inaccurate, and finally that this precise approach to disease management will replace uncertainty and ignorance. Much of this may well be true, and improved diagnostics are certainly of great importance, but in order to really understand their contribution, we might ask what is actually unfolding alongside the vision of a more orderly medicine in low-income contexts. What is being concealed by predictions of a new era of precision medicine and rational treatment?